Thank you, everyone. Thank you for having me. First of all, I have no disclosures. So I was asked to talk about how we manage intracranial pressure. What is intracranial pressure? So this is the pressure inside the head. What is causing that inside the cranial vault? Well, there's only really three things that are inside the cranial vault. And it's a relatively sealed off space composing mostly of the brain parenchyma itself. That's about 80%. But combined with that, you also have the CSF that the brain is enveloped in, as well as, of course, the blood that is entering and exiting the brain and supplying oxygen and nutrients. So that makes up the rest of the 20%. So I think to understand intracranial pressure, the Monroe-Kelly hypothesis is really kind of important to understand. And this is basically that you have these three volumes. And in this case, they split it out into four: arterial volume versus venous volume. So the blood volume is split, the brain and the CSF. And in our normal capacities, that makes up our intracranial pressure. Our pressure is normal. Well, what happens if you introduce some sort of mass, some sort of new? Now, this could come over time, or it could happen suddenly. When it tends to happen over time, or if it's a small volume of additional mass, the brain adapts, and it uses its normal mechanisms to take up that mass volume and still have normal pressure. So in this case, you drain out some of your venous volume, and some of your blood volume is decreased, and some of your CSF can also drain out through the normal brain mechanisms. However, if you have it occur suddenly or to such a large extent, then you can rapidly overcome those compensatory mechanisms, and now your pressure is going to go up. So what can cause this? So as we said, something massive, even if it comes over time, like a tumor, when it gets to a certain amount of point, it's just going to overcome those mechanisms. But you can also have something a little smaller, but happen suddenly, like an intracranial hemorrhage. You can have a large vessel ischemic stroke, kind of like that young child that Dr. Dow just talked about, particularly if the brain is younger and it's more full, that's going to cause a problem more rapidly. But you can have other mass lesions, like in this case, this is an infection with an abscess formation. You can have trauma that causes multiple bleeds. You can have this patient which had a diffuse anoxic brain injury, and so it has swelling all over the brain. So there's not one mass lesion causing a problem here, but the whole brain is starting to swell, and that's going to cause you problems. And you can just have your own CSF volume getting so large, overcoming the normal mechanisms due to hydrocephalus, and thereby causing problems. So why is this so important? Well, I mean, usually these patients are going to be in the ICU, or they're going to rapidly deteriorate and become an ICU patient if this is not treated urgently. But why does this happen? Well, so I think the main thing we're worried about when we talk about just the pressure is really the cerebral perfusion pressure. So remembering cerebral perfusion pressure, it is basically your mean arterial pressure minus your ICP. So in our normal circumstances, when we're thinking about cerebral perfusion pressure, your ICP is normal, your MAP is basically a direct correlate of that. And the blood-brain barrier works in such a way to try to take out any variation in your blood pressure. So this is kind of the normal pattern that you have here. So over a range of perfusion pressures, you have a stable blood flow getting to the brain. So when we stand up, our blood pressure drops a little bit. When we sit down, it may go up, or you lie down, it may go up a little bit. If we didn't have our blood-brain barrier, every time we stood up, we'd pass out, because you suddenly drop pressure across the brain and you drop. So the blood-brain barrier takes that into account, and it works to even those out. However, in a damaged brain, like this one here, now you become a linear association now, and thereby every little drop in blood pressure will cause a problem. And conversely, of course, as I said, if your ICP is going up, now all these ranges have to shift, and that's going to cause more problems as well. So before we get into the treatment, I think it's important to consider, when do we put in a monitor, what type of monitor, things like that. So how would we know? So if we're worried that that the pressure is going up, we should be placing a monitor. So there are some general guidelines. These are taken from trauma, but they basically work. So a GCS less than 8. So this basically means a patient that's not interacting with you in enough way to know that the brain is functioning somewhat normally. So usually an unconscious patient that you don't know exactly why they're unconscious. It's not just a medical issue or something else. If they have significant intraventricular hemorrhage or hydrocephalus, certainly you want to consider a monitor or treatment. And if they have any evidence of herniation, and we'll talk about different types of herniation after. So those are patients that you would consider. So the next question is what type of monitor to place. There are multiple types of monitors available. Probably really the most common ones are the ventricular monitor, the external ventricular drain, EVD, and the intraparenchymal monitors. We used to try these subdural monitors thinking the placement's easier, or an epidural monitor, and the hope was that it's less invasive and thereby less risk. However, they really have turned out not to be nearly as accurate, and basically turn out most of the time you're going to end up having to do something either intraparenchymal or intraventricular. So the EVD, this is probably the gold standard. And this has a couple reasons why. I think here, this has an accuracy that you can keep adjusting for. So patient moves a little bit, you can adjust that. So you can create a constant accuracy, and it tends to remain stable over many days and even longer if necessary. The biggest advantage, this has a therapeutic component here too. You can drain off CSF volume externally, and thereby, again, by the Monroe-Kelly doctrine, give yourself some more space to work with and thereby reduce the ICP. And again, as I said, you can calibrate this as you go along, so you don't have to worry that you're going to lose accuracy. However, this is the most invasive procedure. Here you're talking about drilling a small catheter all the way down to the middle part of the brain, and therefore, you have the highest risks of causing hemorrhages, and other complications. These can be difficult to place in trauma patients that often have, or diffuse cerebral edema patients that have very tiny ventricles. Getting it into that space can be difficult. And of course, you need a skilled neurosurgeon, and you also need skilled nursing to place these. The other thing to be aware of is, these fluid columns that come out of it, the drainage, if they become blocked for any reason, then not only can your measurement become inaccurate or go away totally, but it can also cause, if you were dependent on that drainage, it can cause a rapid decline in the patient. And the other thing is, of course, that's a route for infection now, more so than other monitors. Intraparenchymal monitors are the other main type that are still used, the typical being the Camino and the Codmans. And these monitors, they have a big advantage, is they're much less invasive. This is a probe that only needs to be drilled in about a centimeter or so into the parenchyma, rather than all the way down the 6 centimeters to the ventricles. This can be used well in trauma patients or patients with diffuse cerebral edema, and you're not dependent on that fluid coupling mechanism, and thereby be more easy to maintain. You don't need nearly as specialized nursing for this. It has a much lower infection rate also because of this. The downsides, you have no therapeutic option with this, and you tend to get this loss of accuracy over several days where the number tends to drift away from the true measure. The other big disadvantage to these monitors are they're very point specific. You are measuring the 1 centimeter cubed spot right around the tip of that catheter. You are not measuring pressure on the other side of the brain. So if you put this on normal brain and the mass effect is on the other side, you may be missing a lot of problems. So let's assume we've put the best available device that we have that's needed here, and you get a pressure that is elevated. So what do we do with this? And again, our Monroe-Kelly hypothesis, you're going to compensate to a certain point, but then you're going to decompensate and the patient's going to deteriorate on you. So what can we do when we think that's occurring? Well, first of all, there's a lot of simple things we can do before we get into the more advanced maneuvers. First thing, this is most important, can be done anywhere, doesn't need any particular nursing. Keep the head of the bed up at least 30 degrees. This is good for general ICU care because it reduces aspiration and other complications. But for the brain itself, you're allowing better venous drainage and helping those intrinsic mechanisms to work. Keeping the head straight, make sure it's not crooked on one side or the other. Avoid the tight neckties when they have a breathing tube in place. The respiratory therapists come in there sometimes and they'll tie those things really tight because you don't want that tube moving, obviously. But now you've got something that could be compressing the veins and compressing your venous outflow. By the same mechanisms, if there's elevated intrathoracic pressure for some reason or abdominal pressure, we need to treat those because those are going to prevent drainage out of the head as well. Treating respiratory failure is very important. I mean, beyond the ABCs, obviously. If you're not treating, go back to basics ABCs when there's a problem, you want to, of course, be maintaining oxygenation and to the brain. But in this case, actually, it's not just the oxygenation. We're really concerned about the CO2 levels. And why is that? Because elevated CO2 levels cause vasodilation, and very low CO2 levels can cause vasoconstriction in the brain. So keeping this at a very tight regulatory place is important. Sedation and analgesia then. So now you can actually sedate the patients, and this seems to help ICP. And the reason this, we think, is because the higher metabolism, the more call for blood that's going on, the more electrolytes the brain needs in an agitated state. So if you can quiet that agitation, there seems to be a benefit on ICP often. And here you're generally going to want shorter duration agents and ones that you can adjust quickly so that you can continue to have some sort of exam on the patient. Seizures, by the same mechanism, tend to be bad for ICP. You will tend to get an ICP spike because of the sudden drastic activity in the brain. So prophylaxis, where appropriate, may be very beneficial. Now, typically, the benefits of prophylaxis are really only seen in TBI patients. There's not been any definitive data that it's better to prophylax, say, tumor patients or anything else if there's no history of seizures. And this is because all of our AEDs, even the newest ones today, like Keppra and Vimpat, they tend to have side effects that can accumulate in patients. And so you really have to balance the risks and the benefits here. In TBI patients, this has been shown. In others, we really haven't seen that benefit, and so we don't typically recommend prophylaxis. But if you see a seizure or you detect a seizure, that needs to be treated. Anemia can also potentially worsen edema. And this is because if you have a very anemic patient, now you have a drop in intra-oncotic pressure inside the vessels, and the rest of the fluid is probably going to go out into a damaged area of the brain a lot more. So it's recommended to treat anemia. This is the one case where we also, sometimes we will look at, and we don't have good data for this, but we tend to do it, aiming for higher hemoglobin goals than are typically maintained in other ICUs. The idea is you raise the intra-oncotic pressure, and that will help drag fluid away from a damaged brain and out into the blood vessels so that they can be diuresed out. There isn't great data behind this, but this is something that's often employed, and we will use higher goals than normal for other ICUs. Fever management is very important. This is not uncommon in any ICU, but certainly in the neuro ICU, it's even more common than others. There's a definitive outcome association with worse outcomes. So we definitely know this. What we don't know is why those worse outcomes are necessarily there. We're not even certain entirely of treating fever just for ICP at least leads to improved outcomes, although we've definitely seen that potential, at least in the cardiac arrest literature. So aggressive treatment is recommended, and this may just be typical antipyretics, and surface cooling, or you may consider other cooling methods, cold saline, intravascular cooling, or some sort of other way to achieve core temperature reductions. And generally what we say is avoid hyperthermia. Anything over 38 tends to be bad for the brain, so we want to treat that very aggressively. Blood pressure and volume management is extremely important. Again, remember our diagrams from earlier. We got to maintain that cerebral perfusion pressure. That's what we're really always thinking in the back of our minds when we're approaching patients in the neuro ICU. We should be thinking, what is the cerebral perfusion pressure? And if that ICP is going up, we need to figure out a way to treat that. But the other thing we can do is raise that map or adjust the map as appropriate. So one is making sure we have adequate intravascular volume. Here we want to avoid anything that's hypotonic, because if it's hypotonic, it will get dragged into a diseased brain and cause worsening pressure. So you want to use at least isotonic solutions like normal saline, or you may even want to use hypertonic solutions, but at least isotonic, and avoiding anything that's hypotonic. And the key here is also to avoid hypovolemia. So if you think the patient's hypovolemic, if they've been bleeding out, you need to get volume into them. And you may need to use advanced hemodynamic monitoring here, such as a Swan GANS or something to help you target that and identify the euvolemic state. Conversely, if you overload them, if you just keep dumping volume into them, and you fluid overload them, you can put the heart into heart failure and you've lost any benefit. So that's why you may need that advanced monitoring. And concomitant with this is optimizing the blood pressure. And again, really here, when we say blood pressure, we're thinking CPP in our heads, and we're often doing a mental calculation in our head about really what is the CPP. But we want to optimize our blood pressure so that our CPP is in an optimal range, generally at least 60 to about 80. That's our kind of target for CPP, and we adjust our map depending what we think our ICP is. So permissive hypertension, can be beneficial here. Keeping a slightly higher end is probably better because we know that hypotension tends to be bad, especially if this is an ischemic stroke. You're just adding to the area of ischemia that's already been there. And remember that if you have a big mass or something else, you now have a localized increased pressure going on, and it may be harder to perfuse that region, so you want to be cautious about that. What are medical ways to treat ICP? We talked about sedation and the benefits there, fever management as we talked about. Beyond that is really hyperosmolar therapy. So something with a high osm is gonna stay in our blood vessels and help drag some of the extra edema out of the brain, and then hopefully you can diurese that out so that it gets out of the body. So then that's what mannitol does. Mannitol actually has a twofold effect. It increases the blood-brain barrier spaces a little bit so that it's easier to pull out that edema, and then you diurese that out by the natural effect of mannitol. Hypertonic saline has gotten a lot of use in the last probably 15, 20 years. So this is basically 3% sodium chloride, so just basically adding a bunch of salt into our normal saline, getting it up to a 3% concentration rather than just 0.9%. And this has tended to help, and there tends to be a longer level of control than mannitol. Mannitol, for whatever reason, there tends to be a rebound effect after your initial uses, and it becomes less and less beneficial as time goes on. For hypertonic saline, you tend to be able to maintain the same osmotic effect for a longer period of time. And we typically target around 140 to 150 of a serum sodium, but really this has to be individualized. This depends on what's the sodium range before the patient had ICP problems, what is it, what you're targeting, what is the number when they're having their issues. You want to basically raise that number up above where they were when they weren't having issues. That's really your target. So in general, why we say 140 to 150, this really has to be targeted for the patient in front of you. It is critically important in any patient with ICP issues to avoid a rapid decline in sodium. This can't be stated enough, and indeed I have actually a good case for this. So this is a patient I saw when I had been attending in Dallas soon after fellowship. So this was a young man, I think he was around 45. He was actually in jail. He got admitted to jail the night before, and in the morning they realized he's not really moving one side. And then they took him to the infirmary at the jail. They were trying to understand what was going on. They kind of realized the next day that, oh crap, he may be having a stroke. This isn't going away. They thought it was a seizure, I think, at first. And so they brought him into our hospital, to Parkland Hospital in Dallas. And this was the initial imaging we had. See, there's already a stroke in progress, a fairly large territory stroke. Now, we'll talk on a later slide about decompression, but basically we immediately moved, and I think later that night he got a decompressive hemicraniectomy. And the idea here is basically give that swelling space and have it go outside rather than inside and compress the rest of the brain and cause elevated ICP. So we did that. We did that early. This is the post-op CT the very next morning, and he actually got extubated later that day. He was hemiplegic, he was aphasic, everything you would expect from a large vessel MCA stroke, but he was breathing on his own. He did need a KO feed tube to get tube feedings. He was not the most cooperative patient, I think probably at baseline as well as now with the stroke. But he was doing okay. He was subsequently transferred out of the neuro ICU and up to our stroke unit. And at Parkland at the time, and it's since changed because they built a new hospital, but at the time, the neuro ICU, which had just formed, had formed inside the surgical ICU. And the stroke unit, which had been there for years, was a small unit, very small unit, probably about 6 beds or so, up on the 10th floor. So they would only handle patients that didn't have a breathing tube, didn't need like vasopressors, things like that. So it went up to the stroke unit, and the neurointensivists, we didn't follow the patient. It was on the stroke team. So this is April 10th, and about 6-7 days later, typically beyond our standard windows for the maximal amount of edema, 6 days after his decompression, so it's basically actually almost 10 days after the initial stroke, he now ends up having a run of AFib with RVR. We weren't contacted. The overnight residents ended up calling cardiology because they thought, this is a 45-year-old, why is this guy having this? Cardiology comes, sees the patient, says, hey, his sodium is 150. So drop back a little bit. On the 9th, he came in, he had this edema already forming. His sodium was somewhere in the 140s, low 140s. While we knew we were going to wait till the next morning because he didn't have signs of acute herniation on him, we started him on 3%. His sodium came up to about 150 rapidly with that 3%. We took him to surgery, decompressed him, and then we turned off the 3% and kept him on normal saline only. His sodium by itself stayed in the 150 to 155 range. Without us, we didn't give free water really. I think we were giving small amounts to his KO feed, but we don't give much more than that, and certainly his fluids were maintained with normal saline if they were used. So cardiology came in and says, oh, he's got a massive free water deficit because his serum sodium is 155 and he's otherwise a younger, healthier person. So they gave him D5W. So his sodium went from 153, I think, and it dropped massively to 138 in the matter of a few hours. This is what happened. The patient declined, obviously. He had an enlarged pupil. He had active signs of herniation. We were then contacted. We put him on the ventilator. We hyperventilated him, and we were hyperventilating because we were compensating for the hypoventilation that was occurring as he was herniating. And then, but we also gave him 23% saline. We gave him a bolus of that, and we'll talk about that after this. And we were able to rapidly raise the sodium back up to about the mid-140s, and that resolved his clinical syndrome and resulted in the improvement in shift here that you see on the CT. So this one sent on April 17th is like 11:30 at night or something. And then by the time we did the repeat after these administrations, it's the next morning. But we acted within the hours that were there. he was hurt by this. As you can see, there's some hemorrhage that has occurred now because there was increased shift out, and what was happening is basically the brain over here was rubbing against the bone of the decompression. So despite a very large, good decompression, we gave him so much edema with that D5W administration that he had hemorrhaging along the side of his brain. We didn't end up needing to operate on this, but the patient was worse off. He ended up getting a trach at that point. But he was, again, able to wake up and kind of be aware at least. But it took much longer. So I think there's a good point to talk about herniation. What is cerebral herniation? So, cerebral herniation obviously is part of your brain going out an orifice it's not supposed to be, or into an area of the brain it's not supposed to be. And how do we know that this is happening? While we think about a dilated pupil, acute hemiparesis, or posturing in the limbs, either extensor or flexor posturing, it may be subtle signs such as just even a decrease in mental status and a change in respiratory pattern that might be your earliest clinical harbingers. The important thing here is failure to recognize that a herniation is in progress. These tend to happen fairly rapidly, and so if you don't identify them quickly, that patient's going to decline harder and harder, and it's going to be harder to get them back to where they are. And if you're not catching it in time, these often are fatal, particularly when they're caused by acute issues like strokes. So how do we manage it? A lot of our same principles, all those same principles that we talked about ahead of time, making sure the head of the bed's up, straight, the neck is straight, things like that. Those are all very critical treating respiratory failure. In addition to the hypertonics, the standard hypertonics though, this is now where we get into the more aggressive dosings and we start using 23% saline. So this is a small vial of 30 mLs of 23%, and we push that rapidly over 3 to 5 minutes. So when they originally did these studies, there was a lot of association with hypotension, and that's why they went out to about 3 to 5 minutes. Of course, a lot of these patients are herniating patients. They may have hypotension on their own, so which caused it, it's not clear, but generally we push this over about 3 to 5 minutes. That seems to minimize hypotension that we think is caused because of the drug administration rather than the herniation itself. We're very aggressive in our blood pressure monitoring though, because again, remembering that hypotension here is just going to lead to further infarction of the brain and further swelling and edema. And we monitor our serum sodium levels typically every 4 to 6 hours. You find that checking sodiums more frequently than every 4 hours is not a help because you can't respond fast enough. So let's say, so if you say, okay, I'm going to get it every hour because I want to be right on top of these numbers. Well, okay, so you put in an hour for hourly sodium checks. The nurse goes to draw it. Well, the nurse is not going to draw it at 12 noon. They're going to draw it at 12:15, 12:30 because there's other things going on. Okay, now you draw the lab at 12:30. Okay, now it goes to the lab. Lab takes 20 minutes maybe at least, even in a stat situation. Well, now you're at 12:50. Now that takes another minute or two to get into the computer system, result, boom, boom, boom. Okay, I see that effect at 1 o'clock. Now I'm, okay, hey, I want to increase the 3% or decrease or whatever I want to do. I put that order. The nurse has to go get that sodium change, make the adjustment on the pump. Basically what I'm saying is you're not going to see an effect, and there it's just going to start a change. So you're not going to see effect for probably another hour of what your sodium concentration is going to do. So basically what I'm saying is less than every 4 hours is I don't ever do it. The fastest I'll get sodiums is every 4 hours, most often every 6 hours. And it's a guide as to where you're going. The individual number is not as important as the overall trend that you're seeing because there's going to be variation through the day. The other thing we'll do is give mannitol, but now at much higher doses than before. So when you're talking about herniation, we talk about 1 to 2 grams per kilogram of mannitol to give. And again, this is a one-time kind of effect. It doesn't tend to work over long periods of time, but when you've got an actively herniating patient in front of you, this can rapidly help turn things around, and often these are being given at the same time. The biggest issue with the 23% is that it can cause venosclerosis, and so you can't put it through a peripheral line. You have to use a central line. Well, central line takes a moment to get in place, so we're usually giving mannitol while we're placing a central line, and then we're, at least in the emergency room where we don't have access to a central line right that minute because it's a patient that just showed up, we're usually pushing mannitol as we're doing the central line so we can push 23%. If it's a patient in the ICU, we already have a central line, we'll usually skip the mannitol and go straight to 23%. The other thing you can do is hyperventilate these patients. Again, remembering that hyperventilation causes venoconstriction, so you're decreasing the amount of arterial volume getting into the brain. That can help temporize things when you've got an acutely herniating patient. Conversely, you might cause worsening ischemia, so this should be a very transient use when you're just trying to actively stabilize that patient. You don't want to use this for long term. Ultimately, you are probably going to need something more aggressive like a surgical decompression or clot evacuation, depends on what the cause of the ICP issue is. So decompressive hemicrania for acute ischemic stroke. This is something that has been talked about for a long, long time, and until recently, until 2007, was not really accepted and was heavily debated, and even after 2007, but more recently this is becoming accepted. But the argument here was if you early decompress them, not wait for them to herniate, but you decompress them early and allow them that room to swell, their outcome could be better. The argument that we always used to get, the neurosurgeons were always worried about, okay, but if I do this, now I've got a patient with a big left MCA stroke, they're aphasic, they're hemiplegic, are we really improving their quality of life? Okay, so now you're taking a bunch of patients that would have died and now you're making them heavily debilitated. Are we really doing anything here? So there was all these attempts at trials. It was very difficult to do for various reasons. There were actually 3 separate studies that were tried around the same time in Europe, and they each basically had so few patients that they weren't showing a great effect. However, when they got pooled together, so this is some statistical, manipulation, but they pooled all these patients and they now looked at the outcomes. Early decompression within 48 hours, not waiting for them to herniate, in patients 60 and under, had a significant benefit to these patients. The number needed to treat of 2. There's very few things in medicine get a number of needed to treat of 2 to show a benefit. So for every 2 patients, you're going to get a benefit in one of them. And it didn't just leave patients debilitated and bedbound, which is the big fear. It actually resulted in a significant increase in favorable outcome. So what they talk about favorable outcome here is a modified Rankin score of 3 or less. That has some disability and some help with ADLs, but able to function typically at home and able to function with a little bit of help at home. So it resulted in a significant increase in numbers of 3 and 2, and it actually did not cause a huge numbers of 4 and 5, which was the big fear. These were all patients less than 60, and again, they were treated within 48 hours, and they were non-dominant hemisphere strokes, so that's important to be aware of. Now, we have other stroke data that shows that dominant hemisphere strokes in the long run may actually do better than non-dominant hemisphere strokes. So typically, we don't consider the dominant, which side is dominant anymore, and we do this regardless if appropriate. And there is some benefit to doing this beyond the age of 60, but you do start to lose effect, particularly if there's a lot of comorbidities and things like that. So this needs to be individualized to every specific patient, just like any other study that we do. But there definitely seems to be a benefit here, and this is much more routinely done and accepted now by neurosurgeons than it was in the past. What about for ICH? So we talked about ischemic stroke. What if it's a hemorrhage that caused this intracranial pressure? Generally, surgery is not by the guidelines recommended for intracranial hemorrhage. Typically, because especially for primary hypertensive hemorrhages, these are deep structures that are difficult to get to, and you tend to cause as many problems with surgery as you do just by the blood itself. The exception to this, and there's no doubt about this, cerebellar strokes. Cerebellar strokes, definite benefit to getting decompression and surgical evacuation, particularly if they're larger than 3 centimeters. And why is that? Well, you're causing compression of your brain stem, and this is a rapidly fatal disease if they're not treated emergently. And you can see here, this is one patient that came to us with a near brain dead looking exam initially. We gave him mannitol and 23% in the emergency room. He improved to recover most of his brainstem reflexes rapidly within the next hour after the administration of those medications. And so he was ended up being taken to the operating room by our neurosurgeons, and he had a reasonable outcome. He actually woke up. He did have a tracheostomy when he left our unit, but I believe subsequently to that, he has gotten that removed as well. And he's interactive and working with rehab. But here, again, when you see on the sagittal image here, what is happening is you're having compression of the brain stem. It's herniating both upwards and downwards. So if you don't treat that very rapidly, that patient will die within an hour or two. So I just got through saying that the recommendation is not to go after deep primary hypertensive hemorrhages. I put this out that there are some surgical treatments coming online that seem to potentially have some benefits, but it's not clear. This was a 36-year-old woman that we had seen in our unit. She was hemiplegic, not aphasic at first, but she started to deteriorate over the next 12 hours, probably because of edema that was coming on. And we had Dr. Jefferson Chen had just joined our team, who is a neurosurgeon that has a strong interest in intracranial hemorrhage and neurocritical care, and he is using a new device that's out there and has received some approvals for treatment, though this is not officially recommended by AHA or anyone else at this point. This is still under investigation, but it was a minimally invasive way to try to get to that blood clot. And so they map out the fiber tracks, and they try to respect those as you go in with a kind of a small port. And we were able to see a drastic reduction in the volume of blood there. And the patient seemed to do better. She was able to wake up again quickly. She was able to regain her talking and participate more. She still needed a tracheostomy because she had aspirated when she had first gotten to our unit before arrival. And, we don't know how beneficial these are, and it doesn't seem, our initial results seem to suggest it's not affecting your long-term outcome, but it may reduce your length of stay in the ICU. It may reduce some complications that you can get from long ICU stays. This was a patient that had occurred a similar time period as to our other lady, but our surgeon was not available. And 1 month later, it still has a large blood clot and left our unit trached, pegged, and basically comatose, or minimally conscious at best. And so it was a stark comparison to make at the time. Now, again, caution here is this has not been approved, and there's reasons why. We've tried doing this in other patients and with other locations and haven't seen as good results. So our first case was very drastic in her improvement. Our subsequent cases haven't been that great, and some of them have been good and some of them haven't been, and we're still learning what are the right places to do this. Does this work? It seems to work better with basal ganglia bleeds rather than thalamic bleeds. There's a lot of factors that go into this, so this is not something that should be done routinely, but it's something that high volume centers are looking at more and more. So in summary, when should we consider monitoring our ICP? As I said, the trauma literature suggests that GCS less than 8, significant hemorrhage inside the ventricles or hydrocephalus, certainly, or if there's any evidence of clinical herniation, you want to consider monitoring and treatment of that ICP. An EVD gives you a lot of advantages because you can treat as well, and you get probably longer term data. but it's harder to place and has more complication potential. Medical treatments for the ICP, optimize your venous outflow. I can't emphasize this enough. Basic nursing care can make a drastic difference here. Ensure there's adequate ventilation. Make sure your patient's sedated when this is ongoing. Don't try to wake them up in the middle of a herniation event just to see what their exam is. That's not, if you know they're herniating, sedate them hard while you're trying to get to longer term control. Treat fevers, optimize their intravascular volume, their blood pressure. Hyperosmolar therapy, mannitol, 3%, 23%. These are all very beneficial. Most of them are short-term gains to get you to a longer-term therapy like surgical intervention.